Another Puscast, this one covering the first 2 weeks of February in the year 2019. References as well as links to the various aspects of my growing multimedia empire can be found over at edgydoc.com. Nothing else of note to mention, so let's get on to the literature, shall we? I don't know if you have any spelunkers in your practice or people planning to go to India and get bit by a rabid dog, but there is an easier vaccine schedule for those who need pre-exposure vaccination for rabies. This study was a 7-day course of intradermal rabies vaccine, where they got vaccine on day 0, of course, and day 7, and compared the immune response to those who got it on the standard 0, 7, and 28 days. And they all had protective antibody levels against rabies. Obviously, this is not an efficacy trial. I don't think they had patients go out and get bit by rabid dogs, but if someone is heading off to a rabid area and they're leaving shortly, they only need the 2 doses. If you're interested, the study was in clinical infectious diseases. So, are statins the wonder drug that work wonders? Wait, that's bare aspirin. This study is an association, and association, of course, is not causation. But they looked at the use of statins and the risk of herpes zoster and found that patients on statins had a slight increased risk for developing zoster. The odds ratio, a whopping 1.18. Although having had V1 zoster, I can tell you, it ain't fun. But I suppose the take home for this is that if you have patients on statins, it's probably worth harping on them to get the zoster vaccine, which is both safe and effective. And it's the old saying, what statins giveth, statins take away. It's been known and puzzled on that in non-endemic areas of Africa, a significant percentage of people will be seropositive for Ebola virus, with seroprevalence somewhere between 17 and 33%, depending on the study, the population, and the assay used. This study in Journal of Infectious Diseases, the immune response against 3 different Ebola proteins, and found that most people who were seropositive only responded to one of the Ebola proteins, suggesting that they were not being exposed to a whole Ebola virus, but either cross-reacting with some other protein in the environment or by some magical route only being exposed to the protein in question. They suggest that maybe fruit bats, if they are indeed the carrier of Ebola, contaminate fruit, and the only virus particle that's left behind is the Ebola protein that people eat and then have seropositivity to. To my mind, somewhat reminiscent of people who are indeterminate to HIV, where they get an antibody response to one but not all the proteins on the HIV virus. There's a lot of cross-reactivity out there. And the editorial that accompanies this has a nice discussion of the fact that many other animals have filoviruses, including snakes and the like. And this is an old and ancient virus that has been infecting animals forever. But it has raised the issue as to whether or not these people who are seropositive are protected from Ebola, or if it even means they were exposed to Ebola. And until we get the reservoir for this particular virus, it's going to be difficult to know. I remember the old days back at the beginning of the HIV epidemic, when virtually every patient I took care of was dead within a year of presentation. AIDS was a bad disease back in the day when we had no clue what was causing it and equally fewer clues on how to treat it. So I never worried much about my patients smoking. With a very short life expectancy, why harp on them about quitting cigarettes? Well, nowadays that's not true. This study looked at the impact of cancer in AIDS patients and stopping cigarette smoking and found that even after stopping smoking 5 years ago, HIV patients still had a 8-fold higher incidence of lung cancer. Although other smoking-related cancers remained higher a year after stopping smoking, as time went on, the incidence declined to that of non-smokers. So the take-home is get your HIV patients off of tobacco. Although it would appear that for lung cancer, the ability of cigarettes to induce lung cancer remains elevated long after HIV patients stop smoking. So obviously, it's best never to start. So when you see your HIV patients, get into a DeLorean, go back in time, and take away their cigarettes. And as long as you're seeing HIV patients, a meta-analysis and systematic review suggests the following in HIV patients presenting with CD4 counts less than 100. 6% will have Cryptococcus antigen positive in their blood, a third of whom are asymptomatic, and that these patients do better with 800 milligrams a day of fluconazole than those who don't. And that patients who present being cryptococcal antigen positive do worse in terms of mortality than those who are not cryptococcal antigen positive. Now, about 2/3 of these studies were from sub-Saharan Africa, but I live in the Great Pacific Northwest, which is Cryptococcus central, or at least Cryptococcus gattii peripheral, thanks to an invasion from British Columbia. So I think it's not unreasonable to check cryptococcal antigens in them what present with CD4 counts under 100, even if you're not in sub-Saharan Africa. Us ID docs worry about influenza a lot and watch with some anxiety what is going on with bird flu, H7N9. Now, this study looked at the transmissibility to humans of bird flu in China over a 5-year period. And good news, it doesn't seem to be increasing in its ability to infect humans. And to speak anthropomorphically, I can't see a reason why it would. Bird flu has lots of chickens to multiply in, and becoming more infective in humans would not, to me, seem to be a good reproductive strategy. I know influenza doesn't think that way, but as long as it has plenty of chickens and other birds to multiply in, why would it bother with human beings? So far, bird flu is mostly remaining bird flu with low risk of spreading to humans. I am an adult infectious disease doctor, which is who I treat, not necessarily how I behave. And so I don't pay much attention to diseases of childhood, though I've had to become somewhat expert in the measles of late. I think I've mentioned my disappointment in the Trump administration for not building a wall, although I want it between Oregon and Washington to keep the measles out, and I want Washington to pay for it. Now, I've always been under the impression that the reason you give 10 days of penicillin for strep throat was not to cure the strep throat, but because it was superior for rheumatic fever prevention than shorter durations. Now, I've only seen one case of rheumatic fever in my career, and it has essentially vanished in the United States. But there's this wonderful review called Hostage to History, the duration of antimicrobial treatment of acute streptococcal pharyngitis, that can be found in the Pediatric Infectious Disease Journal. For those of you who constantly fret and are asked about the duration of antibiotics, it is a fascinating exploration of the origin of the 10-day rule for streptococcal pharyngitis. Spoiler, it's not based on anything. And they also note in the article how that 10-day rule has metastasized and has become the standard to many other infections. Quote, augmenting the influence of historical pedigree is the visceral contentment that the number 10 provides and that other contiguous numbers do not enjoy. The number 10 has been occupied a preferred place in human affairs ever since the ancient Egyptians adopted a base 10 numbering system. The number 10 has had potent links with a religious and mystical belief systems throughout human history. End quote. And really, how much of the practice of infectious diseases resembles a religious or mystical belief system? At least that's the impression I sometimes get doing antibiotic stewardship review. But anyway, dig up the article. Read it. It's wonderful. And my bet would be that most streptococcal pharyngitis, which is often a self-limited disease, would probably get better in 3 or 5 days of antibiotics instead. Not that anyone ever will give less than a 10-day course. There is a review this week in the New England Journal of Medicine on aspiration pneumonia. And how's this for hubris? I don't think they got it right. Or at least they're not very specific in their classification, to my mind. Here's my take, and you can take it or leave it. At some level, of course, all pneumonias are aspiration pneumonias. That's how bacteria get into the lower airway to cause pneumonia. So the real question is, what are you sucking into your lower airway? The classic aspiration pneumonias of the 60s and 70s were people who underwent loss of consciousness. They were seizure patients, alcoholics, who had bad dentition. I don't know how many of my listeners have seen what Dilantin does to teeth. And they present with a lung abscess slash empyema that is an indolent, somewhat consumptive process. And when you do cultures of these lung abscesses, there's a predominance of anaerobes and oral organisms. They note in the article that there's been a microbiologic shift in aspiration pneumonias away from anaerobes. But that's because most aspiration events are not an aspiration pneumonia, although they can lead to pneumonia. And the reason that we don't see anaerobes in most aspiration pneumonias is that the pneumonias we are seeing are not the classic aspiration events of the 60s and 70s with lung abscess, but people coming with an acute infiltrate after loss of consciousness and sucking stuff into their airway, which, depending on the clinical situation, may not be even infectious at all and may not require antibiotics, as a recent study showed. I think they fail to make those distinctions clear, and as a result, it's not a very helpful article. And I think that their recommendations for the treatment of aspiration pneumonia are also wrong. They suggest, for example, amoxicillin clavulanate, where amoxicillin plus oral metronidazole is cheaper, has less diarrhea, and probably has better microbiologic coverage of, say, the classic aspiration. And other diseases depend upon the clinical situation under which the aspiration event occurred. It'd be a community hospital or ICU aspiration, where then you have to worry about gram-negative rods, etc. The lack of fine distinction in the various clinical scenarios under which aspiration occurs is really quite disappointing for a review article in the New England Journal of Medicine. So I've probably reached the pinnacle of infectious disease conceit, where I think the New England Journal review got it all wrong, or at least doesn't get it quite right with the subtleties and distinctions that I think aspiration events and pneumonias warrant. So for one of the first times ever, I'd say, yeah, there's a review of aspiration pneumonia in the New England Journal of Medicine. Feel free to ignore it. A couple of years back, I presented a case in my blog about someone who presented with a febrile illness, bright red fingers and toes, and they peeled only their fingertips and toe tips. Is toe tips a word? Anyway, they turned out to have Still's disease. And at the time, the differential diagnosis that I could find was Still's disease, Kawasaki's, and perhaps some staph or streptococcal exfoliative toxins. So it was with interest that there's a report in the Journal of Pediatrics, again, I don't usually read pediatric stuff, about an 11-year-old girl who peeled her fingertips and her finger erythroderma was due to Mycoplasma pneumoniae. So add mycoplasm to the list of unusual processes that make your fingers turn red. My knowledge base on some infectious diseases is remarkably thin. I never treat hepatitis C or hepatitis B. Pharyngitis and otitis media is an outpatient disease I never see. And so are STDs. So I read with interest this article on how to treat Mycobacterium genitalium. The big problem with this organism is resistance. And increasing resistance to macrolides and quinolones is a problem. This interesting study out of Australia did PCRs on patients with non-gonococcal urethritis, and they did gene testing for resistance. And if they found resistance, they followed up a 7-day course of doxycycline with citalfloxacin for another 7 days. And if the patients were negative for resistance genes, after a 7-day course of doxycycline, they finished up with a 3-day course of azithromycin. And they got a 92% cure rate and did not get much in the way of macrolide resistance. Now, as I do this at home on a Saturday morning, I actually don't know if we have PCR for Mycoplasma genitalium in my clinic, and if we have resistance testing by PCR available in my clinic. Maybe you do. But next time, if I ever see a case of NGU again, of which I think I've seen one in my career. I'll at least have this somewhere in the back of my foggy brain for an approach to the patient. I have been around forever. The first steroids in sepsis were released when I was a medical student in the VA back in the 1980s, and the use of steroids in sepsis has come and gone. My theory behind meta-analyses is that if you take piles of cow manure and you put it in one big pile, you get a giant pile of cow manure, not gold. Most people think you get gold. And I'm going to leave the results of this study up to the intensivists to apply, but there was a meta-analysis in the JAMA on the use of corticosteroids in patients with sepsis and found it was associated with a reduced 28-day mortality. And they also found that steroid therapy was associated with, quote, increased shock reversal and vasopressor-free days, and with decreased ICU length of stay, time to resolution of shock, and SOFA scores. I prefer a lazy boy recliner score. So what are we going to do with this meta-analysis? And by we, I mean the intensivists. I'm going to leave it up to them. I've reached a stage in my career where if it's not an antibiotic, it's someone else's problem. An interesting study that looked at the use of azithromycin, predominantly for respiratory symptoms. They found the highest rates were in December and January. So people came in with respiratory complaints. They got a Z-Pak. What happened as a result? Non-susceptibility of gonorrhea also went up during that season. So the use of wintertime macrolides also increases the resistance of gonorrhea at the same time. So if your partner is on a Z-Pak for their cough while you're having sex, you might want to be careful. But I found it interesting how much azithromycin use goes up in the winter, and I find it interesting that gonorrhea is a not-so-innocent bystander becoming resistant because of the other use of antibiotics, which you would expect. And as long as we're on the topic of gram-negative diplococci, this study looked at the epidemiology of meningococcal outbreaks in the United States over a 15-year period. And one thing that surprised me is that outbreaks accounted for 5% of meningococcal disease. With all the brouhaha that we see in the newspapers, I would have thought outbreaks were more common. But they found that serogroup B tends to cause outbreaks in organizations, whereas universities tend to be Group B and community tend to be Group C. So different groups of people tend to have different susceptibilities in the United States to meningococcal outbreaks. I have become increasingly skeptical about the efficacy of probiotics to anything. There are several issues with probiotics. One, what's on the label may not necessarily be what's in the bottle. These products are not regulated by the FDA, and like all supplements, let the buyer beware. Also, sometimes what's in the bottle is dead, and that's not going to help. But when you look at the size of the microbiome in the colon and the number of organisms in a probiotic pill, to my mind, probiotics are like trying to sterilize an Olympic-sized swimming pool by putting in a cup of bleach. Also, gastric acid and or the antibiotics the patient is on are probably going to nuke a significant portion of the probiotics you're taking anyway. Subsequent studies have shown less and less efficacy for both C. diff prophylaxis and for antibiotic-associated diarrhea prophylaxis. And some of the data suggests that taking probiotics not only doesn't work, but it may delay the return of the normal microbiome. Really, if we're going to use probiotics, we should probably wait till we have poo pills rather than using lactobacillus or other species as a surrogate. They're foreign organisms. They probably don't work. You have no idea what you're getting. And as an editorial suggests in JAMA, are probiotics money down the toilet or worse? I'd say yes to both, which has been a change in my opinion over the last decade as it refers to probiotics. I was more optimistic of benefit early on, but over time, nah. I still think the less you do for patients, the better. Rather than don't just stand there, do something, I think patients are best served by the philosophy, don't just do something, stand there. And my wife can validate the fact that I am excellent at doing nothing. There's been something in the news of late that eating processed food increases your mortality. This certainly might be too with prepackaged pouches of liquid herbal tea, which caused an outbreak of botulism. If 2 is an outbreak, I think you have to have at least 3 before you can call it an outbreak. But 2 cases of botulism type A associated with prepackaged pouches, say that 3 times really fast, of liquid herbal tea. There have been, to best of my ability to ascertain, no outbreaks of botulism associated with beer. It's long been known that if you're colonized with MRSA, you have an increased risk of infection in the subsequent year. But is it like the weather? Everybody talks about it, but nobody does anything to change it. This study looked at decolonization in patients who were MRSA carriers at discharge and found that those who were decolonized had a 6% infection rate versus 9% for those who were not decolonized. But this decolonization procedure, besides education, included mupirocin, Hibiclin showers, chlorhexidine mouthwashes, 5 days, twice a month, for 6 months, which I don't think I could get anybody to do. They paid the patients in follow-up, so I'm sure that helped. And the more adherent the patients were to their decolonization, the better the results, with a 40% decline. But it may be worth it because not only did they have lower risk of MRSA, they also had decreased risk of infection from any cause, which probably has to do with chlorhexidine, and they had a decrease in hospitalizations. The difficulty would be in implementing something like this. It was difficult enough with the pre-op decolonization, and it doesn't seem like a regimen that lends itself to adherence. 5 days, twice a month for 6 months. But still something worth looking into. And I read these in the wrong order. This journal article was called Methicillin-Resistant Staph aureus Colonization and Pre- and Post-Hospital Discharge Infection Risk, which goes along with what I said in the earlier article. If you have MRSA, you are more likely to come back in with an infection, 2/3 of whom occur within 180 days of discharge. And it was somewhere between 5 and 11%, depending on which particular population you looked at. Those who acquired MRSA, those who already had it, those who ended up in the ICU. But you can roughly say that within 180 days of discharge, MRSA carriers have about a 1 in 10 chance of being readmitted to the hospital. And 1 in 10 is a nice number because it has the magic number 10, which we talked about earlier in this podcast. A study out of China suggests that you can treat CRE, Klebsiella, and E. coli successfully with tigecycline if the MIC to tigecycline was less than 0.5. Other studies have suggested that when compared to other agents in all the studies, use of tigecycline is associated with double the mortality rate of comparators, 2% versus 1%. This study did not find any mortality association with CRE when using tigecycline, but still, ... An article that suggests that ticks could be a vector for leprosy, as well as a reservoir, and they, wouldn't this be delicious, fed ticks leprosy, and they were able to grow it in tick cell lines and ticks, which could conceivably explain people who have been reported to have leprosy but have no contact with either a leper or an armadillo. It is an interesting hypothesis-generating study. Candidemia often comes from the gastrointestinal tract in patients, overgrowth and subsequent invasion. Interestingly, this study found an association between candidemia and Clostridium difficile co-infection, and they found that 1 in 10 patients with candidemia also had C. diff, which by damaging the mucosa of the GI tract would allow easy access of the candida into the bloodstream. An interesting association, and a practical one at that. If a patient, say in the ICU, had continued fevers after treatment of C. difficile, one would have to worry or wonder about ongoing candidemia as well. Cryptococcus pneumonia can give a false positive Aspergillus galactomannan assay. Keep that in mind as well. And this doesn't surprise me. It's a study out of Japan that looked at antibiotic prescriptions in the ER and found that, quote, more than half of the prescribed antimicrobials were misused and frequently inappropriate for various infectious diseases, end quote. It's amazing how often people give antibiotics inappropriately. And what even boggles my mind more is how blasé we are about it. If we treated cancer with the same ineptitude that we treat infectious diseases, there would be a national shitstorm. The solution, of course, is to only have infectious disease doctors prescribe antibiotics. Not a practical one, obviously. And there's a new tetracycline derivative out in the New England Journal of Medicine this month, shows that it's equal to linezolid for the treatment of soft tissue infections and moxifloxacin for the treatment of community-acquired pneumonia. I can't find on a quick search what it's going to cost. So I'm not certain how this is going to fit into our armamentarium of antibiotics. Part of that will depend upon cost. There are already some cost-benefit analyses on the internet, and I will ignore these. It seems that every time a new, very expensive drug is released, somebody comes up with a way to make it cost-effective in the treatment of patients. And I call BS. And that brings us to the end of this Puscast, a review of the infectious disease literature covering the first 2 weeks of February in the year 2019. References are available online at edgydoc.com, the home of my multimedia empire. Don't forget, I have 4 books available on Amazon: The Pus Whisperer 1, 2, and 3, and Fly in the Ointment, if you actually need more and more Crislip. And really, who doesn't? Otherwise, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation, and take it away, Jeff.